Greetings, everyone, and welcome to the annual Master's Student Presentation. This is such an exciting time of year as we get to hear about the diverse set of analyses and projects that students have been undertaking for the past several months. So for those of you who may never have participated in our presentation rounds before, just to remind you that each student is going to present for 10 minutes, followed by a 5-minute Q&A. But just before we begin, I just want to give a special shout out to all of you who have been primary readers, secondary readers, and advisors. We really appreciate all your help and support. And then I also want to really thank Kristen McCormick and Dina for handling all the logistics to get these presentations underway. So with that, let me introduce to you now our first speaker, which is Haley Brahmbhatt, who has a BA in political science from the University of Pennsylvania. And as you can see here, the title of her presentation is called Pathway from In-Utero Exposure to Lead, Cadmium, and Mercury, Altered DNA Methylation to Childhood Risk of ADHD, a multi-level literature review. So Haley, take it away.
Thanks so much, Kristen. Good afternoon, everyone. I came to Hopkins because there are things in our lives that don't get nearly the amount of attention they deserve. ADHD, or attention deficit hyperactivity disorder, poses an incredible burden on our society, with over 6.1 million children diagnosed in the US as of 2016. It's especially impactful in minoritized groups, which are often underrepresented, understudied, and underreported. I feel strongly that I have found something through my master's essay that should be built upon in our public health, clinical, and advocacy practices. Today, I will share with you the results of a multi-level literature review. First, to start off, a few key definitions so we're all on the same page. Firstly is epigenetics, which is a study of those heritable changes in our genome that don't actually change the DNA itself. These are important because this means the impact of these exposures can be passed down through generations, even after the original exposure is eliminated. For example, a woman exposed to lead when she was 15 or 16 can then pass down the implications of that exposure to a child that she has when she's 30. Next is ADHD, which is a mental disorder that can result in impulsive behavior and difficulty concentrating. This is actually still pretty recent. Diagnoses only became more frequent in the 1990s. Next, we all know what DNA is, that DNA methylation is one type of epigenetic modification, and it is the most studied and arguably most relevant type of modification. It involves the addition of a methyl group, or 1 carbon and 3 hydrogens, to the actual strand of DNA, which can result in either increased or decreased expression of that area of the genome. And lastly are heavy metals, which are a type of chemical that even in the smallest of doses can be incredibly toxic. These include lead, cadmium, and mercury, which I'll be talking about today. This logic model is the basis of this review, and it's built upon 3 main components: an exposure, a mechanism, and an outcome. The exposure is specifically a prenatal exposure, looking at exposures to lead, cadmium, and mercury. Next is the epigenetic mechanism of DNA methylation, which we just discussed, and then the outcome, which is a risk of childhood ADHD. Each of these arrows represents the different potential relationships that were investigated in this review, which is why it was a multi-level review, as there were multiple pathways involved. The review followed a pretty standard literature review process. However, it was more complicated in regards to the search criteria themselves. As I pointed out in the previous slide, there were 3 different potential causal pathways that were investigated. So for each database, I needed to conduct 3 separate searches in order to narrow down on the exact pathways I was interested in. While this did make creating the search criteria more complicated, it did ultimately result in a more thorough and narrow scope for this review. The searches resulted in 788 unique articles, which were eventually narrowed down to 25 to be included within the review. The inclusion criteria included being published after 2010, as epigenetics is a rapidly changing field, as well as prenatal exposure. This was especially important because there were many studies that were ultimately excluded because they focused on an early childhood exposure, adolescent exposure, or even adult exposure, which wasn't within the scope of this review. Furthermore, we also included these 3 specific heavy metals, lead, cadmium, and mercury, which often led to elimination of other studies which focused on metals such as arsenic. So on this slide, I've outlined the 3 main causal pathways that I outlined previously: the strength of the evidence from the studies that were included and the number of studies themselves. So first, we'll look at the potential association between exposure to heavy metals, as well as the mechanism of DNA methylation. So this was separated out by each of the metals, lead, cadmium, and mercury. Each of these studies usually was a cohort style that focused on mother-child pairs and looked at measuring the prenatal exposure within the mother by measuring the level of metal within her blood, and then looked at differential DNA methylation in the child, specifically through cord blood, or the blood from the umbilical cord. For lead, it was strongly supported by the evidence at statistically significant levels that there were differential impacts throughout the genome, meaning that different parts of the genome were methylated differently compared to the mother. For cadmium, evidence was suggestive of a significant association between prenatal cadmium exposure and altered DNA methylation in the cord blood. And for mercury, it was also statistically significant association between prenatal exposure to mercury and differential DNA methylation within the baby. It's also important to note that for mercury specifically, there was one study that suggested that there was an impact on the ratio of DNA methylation within the child, specifically meaning that in the child, the amount of DNA that was methylated versus not methylated actually changed between the mother and child. The next component of the review looked at an association between the exposure and the outcome. So prenatal exposure to heavy metals and the outcome, which was the risk of ADHD. Studies examining prenatal exposure to lead, cadmium, and mercury and the outcome of childhood ADHD were mixed, as only some of the studies suggested an association or a causal link between the exposure and the outcome. Meaning there were a few studies that found that if the mother had a prenatal exposure to one of these heavy metals, their children had significant differences in cognitive or behavioral outcomes at a young age, usually between the ages of 4 and 11. However, not all of the studies included, of which there were 6, noted this change. And lastly was looking at the association between the mechanism and the outcome, which is DNA methylation and the risk of childhood ADHD. The evidence was suggestive of a link between DNA methylation and these symptoms, though specific genes of focus were not identified. It's especially important to note that in these studies, this DNA methylation could be the result of any number of exposures, and we don't know for certain that it was a result of exposure to heavy metals. So we do know that potentially DNA methylation does result in childhood ADHD, but it is not yet clear what types of DNA methylation and what led to it. It's also important to note that of all the 25 studies looked at, only one study looked at all 3 pieces of the pathway, from exposure to mechanism to outcome, which is especially important and unfortunately represents a major gap in the literature. So what do we do now that we have all of this information? Well, this review specifically focused on lead, cadmium, and mercury, as they're included in the top 10 toxicant lists by both the WHO and the Agency for Toxic Substance and Disease Registry. All heavy metals have the potential to have adverse effects on human health. This review is not comprehensive, and intervention should not be limited to just these 3 metals, but should include all heavy metals and toxicants broadly. The first intervention must be exposure reduction. This includes having policies for what are acceptable toxin levels in the general population, how to regulate waste of these metals, as well as how to eliminate their use more broadly. Included policies should be at the international, national, and subnational levels, and specifically should look at those metals which pose a burden in those geographic areas in order to be most impactful. Furthermore, preventing commercial use of these metals is also key, as in many areas around the world, these metals are still used in beauty products as well as children's toys, which can be obviously incredibly dangerous. Next is looking at changes to screening policies. Currently, there is no universal screening for neonates for heavy metals in the blood in the United States. There was previously a policy for lead testing that was eventually phased out in 2009. Currently, the CDC recommends screening for high-risk populations, but it's clear that many might fall through the cracks due to this testing policy, as it is not universal. I recommend that screening should be implemented in high-risk pregnancies and for all neonates. It can also be integrated into preconception planning and counseling. It would be tough to have universal screening for pregnancies because of poor antenatal visit compliance globally and other limiting factors. But many, if not most, births are now occurring in a health facility, both in the US and globally. Catching exposures early is key to creating strategies for intervention and care across the life course, especially when combined with the previous strategy of exposure reduction. And lastly, both the previous responses must be augmented with an increase in public education. This includes providing expecting parents with information about toxic exposures, as well as the general public. Education campaigns should include identifying exposures, figuring out how to minimize them, and how parents and adults can figure out how to reduce these exposures. This can include whether they're in the workplace, in commercial products, through pollution, and other substances. Education campaigns should also be tailored to tackle which metals pose the heaviest burden in a particular area. For example, in the United States, mercury may not be as relevant, but lead and cadmium, especially through smoking and other exposures, can be especially important. Ultimately, implementing each of these three approaches will hopefully work in tandem to prevent exposure as well as allow for earlier interventions. This is especially key as ADHD has huge impacts across the life course, beginning from a very young age, impacting a child's educational attainment as well as their social and behavioral development. There are a number of steps that are needed to advance the knowledge of this review and to have meaningful programmatic impacts. First, there is a need for more research that works to investigate each step of the pathway from exposure to mechanism to outcome. In particular, it would be really useful to have cohort studies that focus on all three of the pieces, like there was one in the review, which looks at, for example, prenatal exposure to mercury in the mother, then looking at differential DNA methylation, and then following those children to see if they have particular cognitive or behavioral deficits as they grow up. Secondly, there's major global disparities in terms of toxicants, levels of toxicants, and the infrastructure that's available to actually address these exposures. Policies and clinical approaches should be informed by these disparities. And lastly, and perhaps most importantly, there's a need for greater collaboration between clinicians, advocates, and public health practitioners. Issues pertaining to environmental justice need a multifaceted and innovative approach that can only be achieved when all of these fields work together in tandem. We need greater collaboration in order to address this issue. Lastly, I'd like to take a moment to acknowledge all of the wonderful folks who supported me through this essay and through this degree. It's been incredibly appreciated. I'm now happy to take your questions. Thank you.
Thank you, Haley, so much. That was wonderful. And I'm going to, again, prioritize student questions first. So as students, if you would like to ask Haley a question, either in the chat or by muting, we'll go from there. So I see already, Gabriella has a question for you. Are there disparities in the US regarding heavy metal exposure?
That's a great question. So I mentioned previously that the CDC currently recommends screening for high-risk populations, and the CDC terms this by saying that children who are eligible for Medicaid are those that are considered as high risk. And so, for example, lead is often something that's associated with dilapidated or old housing, and lead paint and those sorts of things often impact lower socioeconomic status folks. So that is a major disparity that can be seen. We can also see the example of lead in the water in Flint being an example of a major disparity where certain geographic regions or cities might be underserved or over impacted by these exposures.
Okay, great. Tamia also has a question. First of all, great presentation, beautifully and well done. I was curious as to whether you could elaborate more on the negative effects on prenatal exposure to heavy metals, as well as how often those types of exposures occur.
Oh, that's a great question. I guess I just touched on it briefly. So as we know that exposures during the prenatal period are especially sensitive. For example, a particular dose of lead exposure as an adult may not be that impactful, but for a developing fetus can be incredibly significant. And so these heavy metals in particular have over time been shown through studies to have major neurodevelopmental impacts, as well as in many cases result in birth defects if at a really high level. In the United States, compared to globally, there is a lower level of these exposures. However, because of pollution and exposures to smoking and other types of toxicants, there is still a significant portion of the population that faces these disparities and these exposures, making them continue to be relevant. And like we said, even if there isn't a noticeable birth defect, through epigenetics and DNA methylation, it can have impacts across the life course that we simply aren't aware of yet.
Okay. Rachel is also asking, what is the benefit of universal screening versus screening for high-risk populations?
Yeah, so there's definitely a pro and con. Having universal screening is definitely a higher burden of infrastructure and requires much more coordination. That being said, it also ensures that you're catching more of the babies that have this exposure. Only focusing on so-called high-risk populations can definitely eliminate or prevent capturing those babies that have an exposure that was unexpected or through a mother who didn't even realize that she had this exposure. So universal screening is definitely, like it implies, more universal and broader, and hopefully is more likely to address and catch these exposures, allowing for interventions across the life course.
Okay, just one more question then from Amanda Burgess. Did any of the studies take into account naturally occurring heavy metals in the environment?
So because the three metals I focused on were lead, cadmium, and mercury, most of which are present through very particular exposures, whether it's smoking or commercial use or pollution, these studies weren't as relevant. There are other studies that look at a broader list of toxicants that often include those naturally occurring chemicals. So it's tough because even those that are naturally occurring, or maybe they're present in the soil, for example, over time, and can be ingested through food or seafood or those types of things, can still be detrimental. But the studies that I included didn't address those issues.
Okay, well, thank you so much, Haley. Really appreciate it.
Thank you so much. And I will stop sharing.
So now I'm going to ask Rachel to start sharing her screen. Rachel Ciulla comes to us from the University of South Carolina, Columbia, with a Bachelor of Science in Public Health. And as you see here, the title of her presentation is called Expansion of Public Insurance to Cover Doula and Midwifery Care in the United States. So Rachel, you can take it away.
Thank you so much for the wonderful introduction, and thank you all so much for being here. So first, I wanted to touch on what exactly doulas and midwives are. So doulas and midwives are prenatal, birth, and postnatal professionals, and they are a vital part of the healthcare team for many birthing persons. Both professionals can assist birthing persons in hospitals, birthing centers, or even at home births. Midwives are trained medical providers who may go through a few different avenues of schooling and training to become clinical professionals that can provide prenatal, postnatal care, and complete a similar role to an obstetrician during birth, with the exception of an emergency or hospital-bound procedure, for example, a C-section. Midwives can be licensed as certified nurse midwives or direct entry midwives. Doulas, on the other hand, are not medical practitioners in the clinical sense, but are trained support persons who provide education, serve as advocates, and provide physical, mental, and emotional comfort measures to clients before, during, and after birth as a part of the pregnancy care team. This is important to note that doulas can practice regardless of whether the client is in primary care with a midwife or an obstetrician. Both professionals operate on a patient-centered care model and have been shown to increase satisfaction and decrease adverse outcomes in patients and clients. So why doulas and midwives? There is a clear advantage. The first thing to note is that since 1987, maternal mortality in the United States has been on the rise from 7.2 to 17.3 per 100,000 live births, with some states even as high as 30 and some below 15. The pregnancy-related mortality ratio for non-Hispanic Black birthing persons is even higher at 41.7 and 28.3 for American Indian and Alaska Native birthing persons, in comparison to 13.4 for non-Hispanic white birthing persons. Rural populations also face unique challenges as they don't have access to even basic some places don't have access to even basic obstetric care without an extensive commute. Midwifery care is associated with a lower risk of preterm birth, low birth weight, a higher mean birth weight, and a decreased duration of NICU stay. Doula care as well has been found to reduce rates of C-section, low birth weight, preterm birth, epidural use, and increase things like APGAR scores, breastfeeding, the chance of shorter labor, rates of spontaneous vaginal birth, and rates of satisfaction with pregnancy, labor, and the postnatal period. Doulas mitigate the effects of social determinants of health on more vulnerable populations, including birthing persons of color and of the LGBTQ+ community. In 2020, as we all know, the COVID-19 pandemic brought new challenges to care for pregnant patients. There's a higher need than ever for diversified and patient-centered care that's not restricted to the currently overwhelmed hospital setting. So in the current situation, there are 4 states who cover doula services under Medicaid, including Indiana, Minnesota, Oregon, and Nebraska. But legislation related to doula coverage by Medicaid was proposed in 2020 by 16 other states, including where many of us are in Maryland. As far as midwives, only certified nurse midwives and birthing centers that are licensed or recognized by the state are considered mandatory benefits under federal Medicaid, which excludes the other various types of licensed and certified midwife practitioners, a lot of birthing centers throughout the country, and all home births. These exclusions contribute to the existing racial and ethnic disparities of providers in the pregnancy care space. As I previously mentioned, the US maternal mortality rate is 17.3. In comparison to some other countries, the UK has a maternal mortality rate of just 6.5, Australia has a rate of 4.8, France has a rate of 8.7, and Canada has a rate of 8.6. So as you can see, we are almost double. And those services and practices of doulas and midwives have become, somewhat more mainstream. They're often privileges reserved for wealthier, typically white birthing persons due to the incurred expense. The United States has gone through a medicalization of childbirth throughout history. While it's important to note that there have been many advances in science and technology related to childbirth that have saved the lives of countless birthing persons and their infants, it's equally important to acknowledge that there's been a shift in views and reimbursement when it comes to birth. In the earliest history throughout the 17th century, some form of independent or social childbirth was the main practice. There was no intervention aside from assistance provided from a midwife and mainly female community or family support, barring an emergency situation. In the 17th and 18th centuries, physicians, surgeons, and apothecaries set out to discredit anyone who was unlicensed, but the licensure process was not a regulated system and required no formal education or training. With the introduction of these so-called medical men, the overzealous use of interventions actually led to a spike in infant and maternal mortality rates from 1915 to 1930. Historically, the meaningful contributions of marginalized and oppressed populations, including Black and Indigenous people and women, have been exploited and the practitioners themselves discredited. We feel the effects of this in birth work even today, as there exist two approaches to childbirth, the medical model and the midwifery model. And the medical model is viewed, practiced, and reimbursed in the United States as the standard of care. So my position is that the most valid choice of care for birthing persons is a fully informed choice by the birthing person. My position is that Congress must pass legislation to make doula and midwifery services a mandated benefit for the nearly half of Americans who give birth under Medicaid at the national level. This action has the ability to address the crisis of maternal and infant mortality that we currently face. And in fact, there is currently ample proposed legislation at the national level that directly mentions, relates to, or could be enhanced by the inclusion of doula and midwifery services. I have carefully curated the displayed diagram to illustrate these themes in currently proposed legislation. So as we know, policy should be guided by numerous elements, including successful examples. Washington State has higher averages of births attended by midwives and subsequently higher than average rates of positive birth outcomes. One analysis found that higher midwifery integration scores were associated with higher rates of physiologic birth, less obstetric interventions, and fewer adverse neonatal outcomes in those states, but that regulatory environment for payers has been shown to significantly impact the extent of midwifery practice in a state and the impact on the autonomy of midwives. We also see that midwifery is ingrained in the medical culture of other countries with more successful birth outcomes. There are, as previously mentioned, states that currently have Medicaid reimbursement for doula services at varying rates per visit and for labor and delivery. In each state, there is a type of registration and a qualifying system for doulas. The existing methods at the state levels do have flaws to be considered, mainly lack of funding, support and integration, training, and disproportionate gatekeeping and reimbursement. And in policy proposals, it's vital to appeal to stakeholders from various avenues, including cost. So on average, midwives save $2,000 to the patient versus care by an OBGYN. In Washington State, Chief Medical Officer Jeffrey Thompson estimated that midwives saved $3.1 million per biannum costs in offset to Medicaid when birthing persons actually birth at home or in freestanding birthing centers, even at the time with midwives only attending under 2% of all state births. Another study estimated that if each state could reduce its C-section rate by 31.6% with the use of doulas being reimbursed at $200 per birth, savings could surpass $2.5 million for almost all states, as C-sections cost 50% more than vaginal deliveries. So here, lastly, is a few specific recommendations that I have for proposed legislation, mainly surrounding doula and midwifery care included under the U.S. Preventative Services Task Force, freedom of combination of providers and locations, the enactment of a board of representative doulas and midwives should be involved in decision-making and implementation. There needs to be an expansion of funds and reimbursement availability, expansion of access to training and workforce development, including and particularly for communities of color, improved collaboration and support from the medical system, and there should be accountable efforts to increase diversity of practitioners and their availability in underserved areas. I would like to take a moment to acknowledge Dr. Mary Catherine and Dr. Eck for their support in making this body of work possible, as well as my Pop Fam and my family and friends for all of the support throughout this degree.
Thank you, Rachel, so much. And again, I will field some questions here. So I already see you have one from Mariam. And she asked, could you tell us what happens if there's a medical emergency in a patient that's being cared for by a midwife?
Absolutely. Great question. So, as we know, medical emergencies can and do happen in even the healthiest of pregnancies, but midwives are trained to identify these complications quickly and refer their patient to an OB if the pregnancy or delivery at any point becomes high risk.
Great. Okay. Other questions? And faculty, you can ask questions too.
So, Kristen, this is Donna Strabino. So, Rachel, I had a question about the science to support your recommendations, because it's my understanding, at least from the research that's been done on community doulas, that it's been very limited. And in fact, the community doulas, which you are promoting, do not, there's not been shown to have an impact on some of the outcomes you described. That's not true, however, for midwives and nurse midwives. And I, strongly support that recommendation. I've spent a number of years in my career looking at nurse midwives and nurse midwifery models. But can you speak to this push for community doulas in the absence of evidence base, that they necessarily have an impact? And I'm not talking about the evidence in labor and delivery, but really the ones more related to community doulas.
Sure, absolutely. In the, research that kind of led to the foundations for my paper, I actually found extensive research that discussed the, benefits of doula and midwifery care in terms of reduction of adverse birth effects. One author in particular has a few pieces of work that I've cited in my paper. Last name is Comenzil. I'd be happy to email a couple of those papers your way if you're interested.
No, that's fine. But I have it. Given that the studies that really are the most rigorous in terms of internal validity are randomized controlled trials. Because I'm quite familiar with the literature,
Sure.
Those have been quite limited. And so some of the authors or reports are really more advocacy or are based on observational studies. So
Sure.
I'm just sort of a little concerned that there's been a lot of advocacy for the community doulas without an evidence base. And so I just was raising that as a potential constraint in thinking about recommendations moving forward.
Sure, absolutely. And I know that in New York in particular, they have launched a pilot program that deals with Medicaid reimbursement for doulas. And there's extensive research being, hopefully I would assume, collected in this instance. And then, just, anecdotally, we know that the purpose of doulas is to be advocates. And there are, qualitative evidence and, kind of testaments and statements from clients that, discuss how they have been assisted in navigating the medical system and things of that nature. So I absolutely thank you for your comment.
Yeah, thank you.
Okay, I'm just going to ask one more question, I think is all we have time for, but I think Rachel, there are some additional questions that you could maybe address later through email. So I'm going to ask the one from RT, and she says, what subpopulations would benefit most from Medicaid coverage of doula and midwifery services?
That's a great question. So obviously the expansion of Medicaid would benefit all birthing persons who are covered by Medicaid insurance, but it would provide an opportunity for those who are interested in doula or midwifery support, but may not be able to afford it out of pocket. And also populations who suffer from, these racial and ethnic disparities that exist in adverse birth outcomes, including Black, Native American, and Indigenous birthing persons and rural populations. The proposed expansion would also give opportunity for doulas and midwives from these populations to, make a living wage and close service disparities in providing culturally congruent care, which there has been a proven need for.
Thank you, Rachel, so much. Great job. So now I'm going to ask Rebecca Goins to share her screen. We're going to move up the life course a little bit and focus on adolescence. So Rebecca has a Bachelor's of Arts in Global Studies from the University of North Carolina at Chapel Hill. And as you can see here, her presentation is called I Have Gone to 3 Funerals by 16, Youth Homicide and Fatality in Wyandotte County, Kansas, Preventable Deaths in Wyandotte County, Kansas, Youth and Strategies to Reduce Them. I'm not sure if I'm pronouncing that correct, Rebecca, but you can correct me. So you are free. Take the mic.
Can everyone hear me okay?
Yep.
Okay, great. Hi, everyone. My name is Rebecca Goins, and I'm excited to share about a project I've been working on during my AmeriCorps service year in Kansas. The title, I Have Gone to 3 Funerals by 16, quotes a personal account by a resident of Wyandotte County, captured in our community health survey. And for my thesis and my practicum, I conducted data analysis on child and youth violence in Wyandotte County. And for my practicum, I worked with my community to implement a youth fatality review board. Those lessons learned and key steps were incorporated into my thesis, and I'll be going into those briefly today. So this presentation has 4 main sections. First, I will introduce you to my county. Then I will briefly share some data findings from research. Next, I will go into the purpose of a local level review board and then the steps I took to successfully establish one in my county. At the border of Kansas City, Missouri, Wyandotte County encompasses the lesser known Kansas City, Kansas. Wyandotte has a total population of about 160,000 and it's very racially diverse. The majority of the population in Wyandotte are people of color, specifically Latinx and Black. And on the left, that's a photo of me in front of the health department taken about last July. I was helping with COVID testing during my lunch break, and I wanted to put you all there with what my health department looks like. To illustrate the issue of child and youth fatality, here's a graph showing rates over the past decade. There are on average 34 deaths a year in my county, which is enough to fill up a school bus. However, compared to previous years, this past year in 2020 was the deadliest year for children and youth in my county. There were a total of 371 child and youth deaths from 2010 all the way to 2020. And to put that in perspective, this is more than the 2021 Wyandotte High School graduating class. Wyandotte County's manner of death distribution compared to Kansas and the overall United States highlights the issue of homicide in the community. Data indicate that the primary manner of death among Wyandotte County children and youth from 2010 to 2019 was homicide, representing 1/3 of all deaths. Natural causes of death are defined as medical conditions. And if we add up all the deaths aside from medical causes, almost 3/4 of our child and youth deaths in my county are preventable through direct community action. Honing in on homicide specifically, the trend of homicide deaths is pretty volatile, but it shows an overall increase throughout the decade. What is most striking about this cohort on the left is that you can see the rate of homicide more than doubled this past year in 2020. Moving over to the pie chart, the racial breakdown of who is dying is not proportionate to the population demographics of Wyandotte County that I showed you earlier. Racial disparities are even more apparent when looking at causes. The majority of white children and youth have died due to accidental causes or suicide, whereas Black and Latinx youth were mostly murdered in Wyandotte County. Child death review teams have been active in the United States for nearly 40 years. Review board teams are confidential, multidisciplinary groups of people that come together and conduct an in-depth review of an individual's death to understand the circumstances and risk factors that led up to that one person's death to then prevent future deaths. So most of my work this past year in the community was implementing the first county level review board in the state of Kansas. And you may be wondering, well, if Kansas already has a state level child death review board like all the other 50 states and give or take some territories, why does Wyandotte County need a local level one? And the reason is that there are many limitations to the state child death review board. The first being that the data cannot be identified by individual counties. Due to the current state statute, the state board cannot share any data other than what is published in their annual report. Another constraint of the state child death review board data is what is published in their annual report. It does not include any analysis on death disparities by county, not to mention race and ethnicity. The last limitation of the state child death review board is the age range. The reason my county wanted to extend the age of case review to 24 is due to national and county level evidence that age group 20 to 24 is the most at-risk age group for homicide and violence. So all in all, Wyandotte County faces unique challenges relative to the rest of Kansas with its comparably high homicide rate, high rates of poverty, and racially diverse citizens. Listed here are steps I took on behalf of the health department in collaboration with community stakeholders and leaders in child death prevention on both the national and state levels. I will be highlighting 4 of these steps, specifically steps 2, 4, 5, and 7. I selected these for brevity and also because they involved direct community engagement. Step 2 was disseminating a survey across the county. The questions I prompted allowed people to vote or input their responses on key goals and objectives. Even the frequency of review board meetings was decided upon and voted upon in this. Sectors represented in the survey respondents included law enforcement, community-based organizations, government agencies, universities, justice systems, faith-based organizations, healthcare providers, and just regular residents of the community, among many more. A program scope and mission were formed from the survey results I collected. Another important step was identifying the core review board members that we would need to function. This necessitates county government buy-in and willingness to support the review board. A best practice are establishing interlocal agreements, and this requires county commissioner approval and a vote to bind the review board agencies to a commitment to the board. This step involves sitting down with the mayor. I was writing op-eds, presenting the fatality data to the county commissioners. In general, just being an advocate and raising awareness in the county. And I also had a lot of help. Step 5 is not the most fun, but it is very important. Core review board members must be able to share case information to conduct a comprehensive review of an individual child or youth death. This takes the longest, and I'm actually still working on it since, as I mentioned, we had no state statute explicitly permitting this or any precedent in the state. I had to track down agencies to sign business associate agreements, memorandums of understanding, so that data can be shared. We hit many roadblocks, and one of them requiring a complete overhaul of the public health department's data management system, which is still in the works. New processes and systems had to be implemented to ensure a secure data transfer of restricted data. Lastly, all of the previous steps were in preparation to finally convene together. And these first few meetings involved setting process flows, smoothing out bumps as much as possible before beginning the real high stakes death case investigation from the community. And this is a screenshot that I took and I sent it to everyone's faces, but this is during our very first review board meeting, which was about a little over a month and a half ago. So I just want to open it up to questions, but while people are thinking of questions, I definitely need to acknowledge, I don't know if Julianne is here on the call, but I want to thank Julianne Van View. She's the director of the Unified Government Public Health Department where I worked this past year. She left me with the utmost trust and provided me just amazing mentorship throughout this time. And I can't thank her enough for that. And then I also want to honorably mention two folks who I worked really closely with who lead violence prevention in Wyandotte County, Dr. Jamela Watson-Thompson and Vanessa Crawford-Aragon, and their support that they also lended me throughout this process. And then lastly, I just want to dedicate all the work that I did throughout this year, my thesis, this presentation, everything to the children and youth who lost their lives due to active violence, unintentional injuries, medical issues, and suicide in my county, in Wyandotte County. That is all.
Thanks, Rebecca. That's quite a project that you've been undertaking. So yeah, so let's take some questions. So Ishan asked a question in the chat. Do you think that in Kansas, for example, well, first of all, let me back up. I think the idea of a county level review board is really powerful. Do you think that in Kansas, for example, these should be implemented in all counties or priority counties with high child homicide?
So I want to preface by saying I don't want to say that I'm the expert on Kansas. I've lived here for a year. I love it, but I don't want to say that I should speak on what Kansas as a whole state needs. But if I were to give my opinion, I've driven through Kansas. I know how incredibly rural Kansas is. I mean, you can go hours without seeing a house. And so I think in very, very rural areas, it will probably be really challenging. And you might not even have the collaborators that you need at the table on hand so quickly. So I think it would be a challenge. I don't think that it is unneeded anywhere where a child has died. You know, they deserve for people to look into that and how to prevent that for future children. But I would say, given the very rural, the way that Kansas is set up, it's very rural. I'm not sure what would be feasible for a lot of counties across Kansas. But I will say that Wyandotte is, I believe, the second most populated county in the state. And we definitely need it in those areas that are a bit more urban, where we have more populations who are facing these issues.
Okay, great, because that's related to what Emmy was just asking too. She was just asking similarly, are there other places with county level review boards for young persons? Maybe not just in Kansas, but outside.
Yeah, so I'm glad you mentioned that. I'm gonna try and go back to one of my slides. So as you see on here, step 3 is building an external network. So a lot of what I did was I contacted county level and state level review boards all over the country. I was calling up people in Seattle, King County. I was calling up people just over the Missouri River in Jackson County and in Missouri. Missouri has a very interesting state legislation that pretty much makes all of their counties have review boards, but it doesn't really operate in the way that you might think. And in a way that is as effective from what I've heard. And so there's a lot of opportunity there. And so a lot of my background investigation before I implemented this and worked with the community here was just looking into what other counties are doing. And I spoke a lot with counties in Wisconsin. And so all over the country, I bothered many people, but it was really helpful to get that understanding of how other county review boards are functioning. I talked to a few about the age range. It's very rare to go past age 20. And when I spoke to a lot of people, going to 24 was something that they wish they had implemented, or that they wish they could push that policy forward, because that is a really big problem with this age group specifically.
Mhm.
I hope that answers the question, but the answer, I guess, would be, I talked to a lot of people.
Yeah. Thanks, Becky. So one more question from Cynthia, and you mentioned this, facilitating data sharing agreements, which a lot of us are dealing with and finding challenging. So do you have any thoughts about how to facilitate that? What worked well, what didn't work well, maybe?
Yeah, so what worked well was, and COVID made this really difficult, was really just building that relationship with who we wanted to data share with, and making sure that they understood why this was important and why we needed the data. A lot of people in our county, and probably just a lot of people in general, don't even really know what review boards are. Before I started at this position, I didn't even really have that great of an idea, just a very vague idea. And so when you explain that, hey, this is why we need the data, we need to talk about this one child that died, meaning we need to get all the medical records from this one child. We need to get all the school records from this one child. So, we're going up against FERPA, we're going up against HIPAA, and it made a lot of people nervous. So something that really helped was making sure we're inviting them in, saying, not only we want you to data share, but we want you to be on the board and talk about this and provide your professional opinion coming from your agency. And then on top of that, we can't do this without you. We cannot build the whole picture of the child's life without you. And so if you are not able to do this, we will really struggle. And so I guess for us, it was emphasizing the need for this exact person to share the data. But it also, we had to just assure them of our platform, our secure data transfer, just reassure that the data will be safeguarded really carefully, and it would be very limited access, and just reaffirming those more security measures, because nobody wants to get sued or do anything illegal at the end of the day.
Okay, well, great presentation, Becky. Really appreciate it. So we are now going to give it over to Stacy Liu. So Stacy, you can start sharing your screen whenever it's convenient. But Stacy has a Bachelor of Science in Health Promotion, Nutrition, and Exercise Science from Ohio State. And as you can see, her title of her presentation is Infant Feeding Experiences among Parents with Disabilities, an Integrative Review. So welcome.
Thanks, Kristen. All right, everyone. Oops. So at the beginning of my presentation, I really wanted to take some time to talk about language, because part of dismantling systemic issues such as ableism is being mindful of the ways that it's deeply ingrained in how we talk about it. Ableism is a set of beliefs that devalue and discriminate against disabled people, and it's rooted in this assumption that they need fixing. Person-first language is considered a gold standard, and it's something that a lot of you may have been taught to use, but it's not preferred by many people because they feel that it pathologizes their disability and implies that there's something that needs to be cured or removed from them. And this is where many people prefer identity-first language, because it's like they're reclaiming their disability as a really important part of their identity. So I also want to go through some of these definitions about the disabilities that I will be talking about today and give you some examples. Intellectual and developmental disabilities are disabilities like autism, Down syndrome, and also include sensory processing disorders. Physical disabilities are like the loss of a limb or the impairment of a body component, so being blind or being deaf. Psychiatric disabilities are mental health disorders like depression, anxiety, schizophrenia, bipolar, and not all people with mental health disorders identify as having a disability, but some do. And then multiple disabilities are when there's a co-occurrence or overlap of multiple disability types. So these definitions are really, really helpful for us to use to organize and categorize the different disability types, but really strict interpretations of them don't necessarily reflect how all people identify. So at the end of the day, it's important to ask the person what kind of language and terminology they use, and then respect and affirm their preferences. So throughout history, people with disabilities weren't even respected as human beings, and forced sterilizations occurred for a really long time. It wasn't until the 1990s, so 30 years ago, that policies like the Americans with Disabilities Act were enacted to finally protect the rights of people with disabilities. And even still, gaps remain, particularly in the sexual and reproductive health rights and parenting rights of people with disabilities. So for my review, I was really interested in the infant feeding experiences of parents with disabilities, specifically from their perspective, because I felt it was important to capture their perspectives and not have other people speaking on their behalf. So for my integrative review, I followed the 5-stage approach that's recommended by Whittemore and Knopfel. So in my first stage, I identified a problem, and that was the paucity of information regarding infant feeding experiences of parents with disabilities in the United States. In my second stage, I conducted my literature search, and I used a two-phase search strategy. In my first phase, I worked with the Hopkins informationist to develop these intentionally broad search terms. I wanted to make sure to capture different disability types as well as different methods of infant feeding. And then in my second phase, I hand searched the reference lists of my included articles just to make sure I didn't miss anything in my database search. And then in my third stage for data evaluation, I screened articles for inclusion based on criteria, which you will see on the slide after the next slide. In my fourth stage for data analysis, I created 2 tools in Covidence. One was for data extraction, so like sample size, sample characteristics, and then one was for quality assessment. I used different quality assessment tools to evaluate the strength and the quality of the evidence for each study type, and I've listed them out on the right for you. And then in my 5th and final stage, I took all the original themes and sub-themes directly from the qualitative articles, studies, and I was constantly comparing them and categorizing them and repeating that process in several different ways to eventually identify themes and sub-themes. So after searching these 5 databases, I ended up with a little over 5,500 articles that entered title and abstract screening. And then after going through the whole process, I had 5 articles included for data extraction. Of the 5 articles, only one was quantitative, and this was a secondary analysis of a population level database in Massachusetts, and it was more focused on the pregnancy and birth outcomes, but they did report a breastfeeding rate of 49.4% at discharge, and that's much lower than the national rate at birth of 84.1%. The study yielded an overall weak score on quality assessment due to selection bias and difficulties with assessing withdrawals and dropouts. For the 4 qualitative studies, overall, the quality of the evidence was really strong. And just to talk through them really quickly, going chronologically from top to bottom in this table, the Chin study in 2013 used a community-based participatory research approach, and they interviewed deaf parents about their infant feeding experiences. And this was the one qualitative study that received a perfect score on the quality assessment because the researchers did a really good job addressing their biases and placing themselves in the context of their research. The Gardner 2016 article was a secondary analysis of a qualitative data set, and they focused on the overall childbearing experiences of autistic parents. The Powell 2018 study interviewed physically disabled parents about their infant feeding experiences, and then the Andrews 2021 study used a participatory action research approach, and they interviewed a diverse group of parents with different disability types about their infant feeding experiences. So again, I want to reiterate that my terms were intentionally broad to include different methods of infant feeding, but the focus just ended up being all on breastfeeding. So as you can see here, 2 themes emerged and each of them had 3 sub-themes. I'm going to start by talking about the facilitators to breastfeeding first. And I'll highlight the adaptive strategies to breastfeeding shortly, but I'm going to briefly walk through these other two sub-themes right now. Accommodations from healthcare providers look like doctors knowing how to use American Sign Language, or lactation consultants being really supportive and getting creative with modified breastfeeding positions. Support from the disability community was like getting advice from other parents with similar disabilities on specific techniques that were helpful for their specific disability type. And so reading through this quote, as illustrated by this quote from a physically disabled parent, parents use different strategies, so like modified positioning, technology, equipment, and physical assistance from others in order to learn and implement breastfeeding. And now I'm going to move on to talk about the barriers to breastfeeding. So for disability-related challenges with latching and milk supply, let's take, for example, an autistic parent who probably found breastfeeding to be a particularly overwhelming and difficult sensory experience because of their sensory processing difficulties. And then for this general lack of information and awareness about disability-related challenges with breastfeeding, one example is how lactation consultants would say instructions like, oh, right over here or right over there to blind parents, which those instructions didn't really make sense to them because they couldn't see. So honing in on this sub-theme of breastfeeding ability conflated with parenting ability, in this first quote from a physically disabled parent, you can see that parents felt judged by others for their parenting abilities due to this rigidity about breast is best. And it can be particularly scary for parents with disabilities because they are at greater risk than non-disabled parents of having their children permanently removed from them. So to summarize, here are some key findings from my integrative review. First was that all of the themes were about breastfeeding. The quantitative study also only reported a breastfeeding rate and no other infant feeding outcomes. Second was that there were several facilitators to breastfeeding that were identified, but it's important to note that they were mostly representative of the experiences of deaf and physically disabled parents. So they're not representative of the experiences of parents with other disability types. And then third, these challenges with low milk supply and latching, difficulties with healthcare providers, and this lack of knowledge or information about breastfeeding are also similar barriers that are identified in the general population. But the thing with parents with disabilities is that they experience additional challenges due to their disabilities. All in all, these findings are very important, but the implications of their findings are limited to the specific disability types represented in their studies. In addition, their findings are not generalizable to people of color, individuals with lower education levels, LGBTQ+ parents, and parents who don't identify as women or mothers. In conclusion, we really don't know much about the prevalence of breastfeeding or other infant feeding practices like infant formula use among parents with disabilities. And we also don't know what their infant feeding decision-making processes look like. But improving our understanding of their experiences will ultimately help us to target interventions and better equip healthcare providers to provide those infant feeding supports for parents with disabilities and to address a diversity of needs. And before I close, I really want to take some time to acknowledge some really important people. So Kristen and Gilbert, thank you so much for keeping us all organized and on track to graduate. And to my mentors, Susan, Allison, and Kristen, thank you so much. You guys have given me so many opportunities to learn and grow, and you shared so much knowledge with me. And then to my cohort and the group chat that saved us, thank you guys so much for making this experience really fun. And then finally to my friends and family, Kat, Yenju, Jack, and of course, Zim. Thank you so much for making the tough times fun times. So thank you all so much for your attention, and I will take questions at this time.
Fabulous job, Stacy. And we can't forget Zim, right?
We can't forget Zim.
Okay, you already have a question from David, so I'm just going to go ahead and ask his first. But he says there are parents and others in the community that don't or will not accept the characterization of a particular disability. Were they included in relevant studies? And from your perspective, how do you respond to them?
So I think this is talking about challenges with identifying disability. So it's a really good one. Thanks, David. They talked about this in the studies because they also had difficulties with this as well, because for some of them, parents were allowed to like self-diagnose their disabilities. So there are some limitations with that. And for others, they did require a formal diagnosis. And the quantitative study actually used ICD-9 codes. So the actual identification of disabilities makes it kind of difficult to study. And also because people are not comfortable disclosing their disabilities because of the stigmatization and this higher risk of having their children removed from them. So to answer your question, David, yes, parents who self-diagnosed were included in some of these studies, but it is an ongoing challenge in disability research. So I hope I answered your question.
Oh, yes. Always doing a great job. Thank you.
Thank you.
Okay, another one from Ellie. She says, could you elaborate more on what an integrative review is and why did you choose it?
Yeah, so integrative reviews are kind of like a newer type of review. So integrative reviews are better suited for comprehensively looking at phenomenon or emerging healthcare problems, and also when there's like a diversity of methodologies that are being used. And so with this literature, it's very new and there's not that much research in it. And so I chose to do an integrative review because I was kind of expecting there to be different types of qualitative methods used, and I was hoping to find something quantitative. So I was kind of preparing for diverse methodologies that I would have to synthesize. But although it is helpful for synthesizing diverse methodologies, that is also one of its biggest limitations, because the complexity of integrating those diverse methods introduces greater risk of bias, and there's lack of rigor. And because it's new, they're not like standardized procedures to do integrative reviews quite yet. So thanks, Ellie, for the question.
So because of time, I'm just going to give you one more question from Ishan, but there are probably going to be other questions, Stacy, that you can answer after. But Ishan asks, what sort of studies and research would you like to see on this subject going forward?
Yeah, thanks, Ishan. So so the two qualitative studies that we're doing, community-based participatory research and the participatory action research approaches, I think we need more of this, really, to not only hear directly from the voices of people with disabilities, but to engage them in research, because for a long time, research has excluded people with disabilities and we've also dehumanized them. So I think that we need to include them in the actual research process, so they help us with designing these studies in a way that is respectful. And I think that's kind of the only way that we can kind of deconstruct the ableism that's built into research already, is to include them in the processes, and then to focus on directly interviewing parents about their experiences. Although the perspectives of caregivers and family members, those are also really important, but so much of research is about how people with disabilities impact other people's lives, and not so much about how people with disabilities have lives of their own and how they're impacted as well. So I think that's where the field needs to go, is to involve them in research and speak to them directly.
Thank you, Stacy, so much. Such a great topic.
Thank you all.
Okay, so now I'm going to give it over to Mariam Salama, who is our last presenter for today. She has a Bachelor of Arts in Global Studies and Physiology from the University of Minnesota. And as you can see, the title of her presentation is called Implementing Sexual and Reproductive Health Services at the Acute Stages of Crisis, Challenges and Barriers to Rapid Response. So welcome, Mariam.
Hi, everyone. Thanks, Kristen, for the introduction. So before I begin, I wanted to offer a very brief trigger warning for those of you on the call, as this topic does include some brief discussion on sexual violence. While it's not a focus of the talk, there will be a couple sentences here or there. So for anyone who would perhaps like to mute me on occasion, run and grab a snack, go to the bathroom, I want to make sure that you know that that is coming. So for those of you whom I haven't had the pleasure to meet formally, my name is Mariam. For my master's essay, I decided to combine my interests in reproductive health and in humanitarian health by conducting an integrative literature review, much like Stacy, which sought to understand the challenges and barriers to rapidly implementing sexual and reproductive health services, particularly at the acute stage of various humanitarian crises. So as many of us in PopFam are aware, the 1994 International Conference on Population and Development in Cairo, Egypt, placed a renewed emphasis on sexual and reproductive health as a human right. The ICPD Program of Action was the first clear articulation of SRH as a human right that also offered explicit recognition to refugee and internally displaced persons occurring amidst the backdrop of conflicts such as the Rwandan genocide and the former Yugoslavia that gave rise to egregious levels of sexual violence against women. Here's a brief excerpt of the Program of Action that highlights the emphasis on SRH as a human right. So between 1994 and 99, there were a number of humanitarian SRH focused groups that arose as a result, such as the Interagency Working Group on SRH, or better known as IWAG, who worked to develop the first set of guidelines on the minimum initial SRH services that must be implemented at the acute stage of any crisis. These are also known as the minimum initial services package, which I'll get into detail into in just a moment here. There is a field manual that details how to implement SRH services, which was then created in 1999, which you can see on the left-hand side, along with the distance learning module on the minimum initial services package. Both the MISP and the field manual have just recently undergone revision as well, just as recently as 2018. And so these recent revisions were actually what led me to the basis of my essay inquiry. So namely, what has changed in the time since the ICPD conference? And more specifically, what challenges and barriers persist in offering comprehensive SRH in crisis settings? And finally, my most novel question, which I didn't see in the literature that I was looking at thus far, is what challenges, if any, are unique to the acute stage of response? So with that, for the sake of time, I won't go too into depth about the MISP, but I thought it would be necessary to share with you all the 6 objectives listed in the 2018 revision, which include identifying an RH lead to coordinate response, preventing and responding to sexual violence, HIV and STIs, maternal and newborn morbidity and mortality, and unintended pregnancies. The final objective addresses integrating these services as quickly as possible into the local primary healthcare system. So shifting gears towards my methods section, I broke down my inquiry into 4 manageable steps. So the first was to identify peer-reviewed literature on coordination of SRH services at the acute stage of various individual crises, extracting data that spoke to the challenges of SRH response, and then organizing these data points into a larger table with columns that were divided by their respective MISP objectives that we just reviewed. The third was identifying themes and any possible trends over time. And then the final was then offering recommendations that would perhaps address gaps that hinder rapid response. So as for my search strategy, you can see the databases I consulted on the left, having received an outrageous amount of help from the wonderful Claire Tews, our informationist. My inclusion criteria can be seen on the right, including but not limited to studies focused on a crisis or disaster setting, and those that explicitly address the acute stage of response or the first few months of establishing SRH services in a camp setting. It should also be noted that an acute stage was considered to be roughly 6 months to 1 year at the absolute most from crisis onset. So you can see from the bottom here that out of the 975 titles originally imported, these criteria amounted to a whopping 9 studies. So shifting to results, while several themes emerged despite the paucity of literature, I'll be highlighting 4 that stood out to me the most. So the first is that in the 9 articles, only 2 mentioned a leading reproductive health coordinator or lead organization that was put in place, which explains a lot of issues such as inadequate organization of SRH response at large, issues with procurement and distribution of provisions such as medications and supplies, and poor education dissemination on sexual and reproductive health and where certain services are available during crisis. Next, the response to gender-based violence, such as sexual violence and intimate partner violence, were inadequate in most settings. with most studies citing stigma that contributed to fears of retribution for reporting, inadequate protections or privacy in place in camps, such as lighting around latrines, or lack of privacy in clinics, poorly organized referral systems, and mistreatment of survivors of sexual violence, such as reports of withholding emergency contraception from survivors of rape. Next, a lack of trained providers was noted across nearly all objectives, with providers either being too scarce and or not consistently trained in SRH response. And finally, transportation barriers were cited across the majority of studies due to the deterioration of infrastructure. And this hindered both the transport of patients, such as pregnant women who were experiencing emergency complications, HIV patients who were trying to remain on their treatment regimes, and also hindering the distribution of necessary provisions, reproductive health kits, family planning contraceptive services, and various other supplies. Thus, my proposed solutions included establishing regional humanitarian RH response working groups, which could include reduce a myriad of gaps, such as lack of RH response leads and better tailor responses to the social and cultural context of their respective regions, perhaps destigmatizing a lot of SRH response tools and services that would ideally be available. This was actually a concept that IWAG has discussed a couple of times over the years from what I've been told. Having said that, we can all imagine that there are substantial financial and logistical barriers that are in the way of being able to implement such a thing. The next is prioritizing educational interventions on sexual and gender-based violence that are explicitly centered around men and boys, and also could include community and religious leaders in order to continue to try to reduce stigma, especially since men are often the most common perpetrators of such violence, and yet they seem to very commonly be left out of interventions that include education and knowledge dissemination. When possible, prioritizing provider training in anticipation of crises, such as in regions that are prone to cyclical climatological disasters like routine flooding. Of course, this may be more difficult to anticipate conflict onset, but additionally trying to sustain any training programs through the crisis response, as settings that did this tended to fare better over time. And finally, the proposal that most caught my attention as I was reading would be sort of trying to respond to gaps in transport by perhaps pre-positioning water ambulances in regions prone to flooding, although of course certainly another expensive option. And also initiating the pre-positioning and use of the most recent drone technology available that could serve to deliver reproductive health kits, medications, and other provisions in hard to reach areas. So as for limitations, since this review only included 9 titles, the most obvious limitation is the paucity of literature on the topic, as well as the varying quality of the studies. This also made it very difficult to try to synthesize findings by settings or crisis types, assess trends over time, that sort of thing. And finally, a more comprehensive portrait of SRH response at the acute stage of crisis could be painted by including valuable grade literature sources, key informant interviews, and the like. But for my purposes, and for the sake of our master's essay, I only exclusively decided to look at peer-reviewed literature. So to conclude, overall, several studies offered some amount of indication that SRH responses in humanitarian settings are being better prioritized to some capacity, and the quality and availability of several services are increasing, such as for the treatment of HIV and STIs, considerations for reducing maternal morbidity and mortality, and the availability of several family planning options. Having said this, little to no evidence points to comprehensive SRH responses that have been able to fully implement the MISP, with inconsistencies in procurement and availability of certain treatments and services, and of course, stigma and oftentimes national or localized opinions deciding to leave certain things out of MISP provisions. Additionally, it should be noted that of all objectives in the time since ICPD, there has been very little improvement regarding attitudes towards the availability of abortion and post-abortion services, and issues of gender-based violence still persist despite some interventions and resources that are sporadically available. Fortunately, most all of these gaps are addressable, given some of the recommendations that we've mentioned in the prior slide, among other intervention opportunities that could reduce gaps in response. And these findings mostly reaffirmed prior similar assessments, although these findings were not entirely conclusive for challenges that are specific to the acute stage of crisis versus prolonged crises, for example. And so finally, the implications of this research include the aforementioned practical applications that embrace regional thinking, technological advancements, among others, to reduce gaps in response. And future research should absolutely seek to include valuable gray literature sources that offer evaluations of SRH responses in various crises, as well as including key informant interviews with experts on SRH response in crisis settings, as well as healthcare providers and responders on the ground at these crises. So to conclude, I would like to sincerely thank my readers, Dr. Cortland Robinson, and my advisor, Dr. Donna Strabino, for their critical insights and encouragement, as well as my peers who have gone above and beyond to support me and all of us together throughout the course of our careers at Bloomberg School. So with that, I would be very happy to take your questions, and I hope you enjoyed the presentation.
Wonderful, Mariam. So you're already getting questions. So let me start with Morgan. Morgan asked, could you tell us more about the recent MISP and interagency field manual revisions that you mentioned were just released a few years ago?
Yes, I can. So just give me a moment. I can pull up the slide here with, this is what the current package looks like. So this is the 2018 revision. The most major difference is that before the most recent rendition, there were only 5 objectives, and they added a new objective, which is this 5th one, preventing unintended pregnancies, which was really meant to bring family planning methods, encouraging contraceptive use to the forefront of conversations and procurement, distribution, organization of SRH responses in humanitarian settings. It might seem a little bit weird that unintended pregnancies weren't originally thought of until 2018, but that actually isn't the case. This very much was a part of the minimum initial services recommendations, but it was included as an additional priority or an other priority, which is where currently provisions for abortion and post-abortion care still sits. So preventing unintended pregnancies was originally in that camp, and then it got pulled out to be an objective. It's interesting because that was sort of one of the reasons why I started thinking, well, maybe I could do a review of the literature about this. And I wonder if there's any evidence that, since this new objective has been listed, whether it's made a difference in settings. But that would have required a lot of literature to be published between 2018 and 2021 that would evidence some amount of difference. And I found 9 sources between 1999 and now. So we shifted gears a little bit. But thank you for the question, Morgan.
Okay, I'm going to jump to Court's question. He's asked, as more and more people remain in protracted displacement and humanitarian crises, how do we address ongoing SRH needs in a variety of settings and contexts, even as we try to address acute needs and rapid response efforts? And he just adds, COVID-19, for example, remains acute in many places, but it is likely to become a chronic, ongoing emergency. And climate change displacement is another example.
That is quite a question, Court. Let me pull it up really quickly so that I can read it, because I think there are a lot of components to the question. I think what's interesting about what I tried to do here is, unfortunately, I don't think I can answer the question as comprehensively as I would like to, because I really tried to limit to the acute stage or the first 6 months of response to sort of see what could be integrated into scale up. But having said that, I think just in general, when it comes to SRH response in humanitarian settings, a lot of the most prominent leaders in IWAG have sort of consistently called for the need for more thorough evaluations of SRH responses in these settings so that we can get a better idea of how certain components of the package are implemented and what the drawbacks are, so that we can be able to assess greater themes. So I would assume that it's very similar in that regard with protracted displacement. And of course, I think it's difficult to sort of have conversations about, what to broadly do about humanitarian settings, since they vary so wildly based on, the context of the locations in which they occur, which is why the hope would be in more recent sort of in the recent or in the near future to be able to sort of try to focus on what localized responses could look like, or what sort of local or localized groups or regional groups could be, to be able to create solutions that better fit context, especially for prolonged crises where a lot of the issues that sort of continue to occur are perpetuated by the social and cultural landscapes of those regions, as well as sort of this lack of attractiveness of prolonged crises that sort of end up getting pushed aside when it comes to funding and priority. I hope that answers your question a little bit.
And Mariam, there are other questions, but I think I'm going to just ask you a really quick question because the time is over. But just why did you decide to have your inclusion criteria for your study be 1999? Was there any particular reason?
Yeah, so that's an easy one to answer. So I think one of the things that I was thinking about was I wanted to be able to go from a year, the year that the very first interagency field manual was released, which was 1999, because then in my brain, it sort of made sense that, well, now all of the information in this very easily readable packet is available. The interagency field manual really does try to list out step by step, here are all of the objectives in implementing SRH response in the field. And this is how you can go about doing it with examples to be able to walk through it. So my thought process was, if that was available by 1999, then ideally all of the crisis responses following that date would have this available. Now, what they did with that information is sort of the key question.
Okay, well, thank you so much, Mariam. Great job. And there's more questions and comments that you can look at through the chat. But I want to thank you. I want to thank the rest of our amazing presenters today. I certainly learned a lot. And so great job, everyone. And until next time, we will meet again for our second round. So thank you all for participating. Really appreciate it.